Hi everyone, my name is Tiffany Kindrat, and this presentation covers disparities and cognitive limitations with and without diabetes among Arab American immigrants. This slide covers the main findings. Arab American immigrants had a higher prevalence of cognitive limitations with and without diabetes compared to US-born non-Hispanic whites. Arab American immigrants had a lower prevalence of cognitive limitations only, but a higher prevalence of having diabetes among those with cognitive limitations compared to foreign-born non-Hispanic whites. This slide goes over my introduction and aims. Cognitive limitations are early indicators of Alzheimer's disease and related dementias, which affect 6.2 million U.S. adults. 37% of older adults with ADRD also have diabetes, ADRD standing for Alzheimer's disease and related dementias. Arab Americans are often absent from studies because they are not classified as non-Hispanic whites. Arab Americans typically are not included in studies on ADRD and cognitive health where other groups such as non-Hispanic Blacks and Hispanics or Asians are included. There remains a gap in the literature on cognitive disparities and comorbidities, specifically diabetes among Arab Americans. Therefore, my aims are to estimate and compare the prevalence of cognitive limitations among Arab American immigrants compared to U.S. and foreign-born non-Hispanic whites before and after controlling for covariates. Among adults with cognitive limitations, my aim is to estimate and compare the prevalence of diabetes among Arab American immigrants compared to U.S. and foreign-born whites before and after adjusting for these same covariates. This slide goes over my methods. For my study, I linked 2000 to 2017 NHIS and 2001 to 2018 MEPS data. NHIS is the National Health Interview Survey, and the MEPS is the Medical Expenditure Panel Survey. My independent variable came from the NHIS. This is a combination of race, ethnicity, and nativity status. I'm comparing disparities between U.S. and foreign-born non-Hispanic whites and foreign-born Arab Americans born in the Middle East geographic region. The dependent variable is cognitive limitation and cognitive limitations with diabetes. Cognitive limitations are assessed by the MEPS by any responses yes to the following questions: whether or not an individual experiences confusion or memory loss, has problems making decisions to the point that interferes with daily activities, and requires supervision for their own safety. Cognitive limitations with diabetes was assessed among those with cognitive limitations who reported yes to ever being diagnosed with diabetes. The covariates that were adjusted for in my regression models came from the MEPS. These are potentially modifiable risk factors across the life course identified by a paper in The Lancet by Livingston and colleagues in 2017. These potentially modifiable risk factors include early life risk factors such as less than ninth grade education, midlife risk factors of hearing loss, hypertension, and obesity, and late life risk factors of smoking, depression, physical inactivity, social isolation as measured by marital status, and diabetes for our cognitive limitations only group. This slide presents the results of the age and sex-adjusted prevalence of cognitive limitations among U.S. adults ages 45 and older, as well as the prevalence of diabetes among adults with cognitive limitations. Here you can see that cognitive limitations, the prevalence was 7.3% among foreign-born Arab Americans compared to 8.1% among foreign-born non-Hispanic whites and 6.7% among US-born non-Hispanic whites. Among those with cognitive limitations, the prevalence of diabetes was highest among foreign-born Arab Americans at 27.5% and lowest among foreign-born whites at 24.2%, and the prevalence among US-born whites was 25.1%. This slide presents the regression models for cognitive limitations only. Here you can see that there are no statistically significant differences between Arab Americans and US-born non-Hispanic whites. However, there are differing trends in the point estimates. In the crude model, there's really no difference between Arab Americans and US-born whites, with an odds ratio of 1.02. This increases to 1.14 after adjusting for age and sex. This stays pretty consistent after adjusting for early life risk factors of education, which is measured as less than high school education or less than secondary education at 9th grade. Then the odds ratio actually increases to 1.49 after adjusting for midlife risk factors of hearing loss, hypertension, and obesity. This decreases then in later life after adjusting for smoking, depression, physical inactivity, social isolation, and diabetes. Among these characteristics, Arab Americans have fewer females in the sample. They were also younger. There were fewer adults ages 65 and older. And more had lower education than US-born whites. Arab Americans had less hearing loss, less hypertension, and less obesity than US-born whites. They had lower estimates of being current smokers, yet higher estimates of depression and being married and physical inactivity as well as diabetes than US-born whites. This table presents the results of diabetes comorbidity among adults with cognitive limitations. Again, you can see here that there are no statistically significant differences between Arab American immigrants and US-born whites. However, there are differences in point estimates that show changes across the life course. In the crude model, the odds ratio is 1.17. This stays pretty consistent after adjusting for age and sex, like our previous table. However, this decreases to 0.91 after adjusting for education as less than 9th grade or secondary education. Then this jumps back up in midlife to 1.16 after adjusting for hearing loss, hypertension, and obesity, then decreases down to 0.54 after adjusting for smoking, depression, physical inactivity, social isolation. And we did not adjust for diabetes in that last model because it was part of the outcome measure. So those are the results of my study. I would like to acknowledge the funding from the Michigan Center for Contextual Factors in Alzheimer's Disease, which is a resource center for minority aging research funded by the National Institute of Health and the National Institute of Aging. These data were analyzed at the Dallas-Fort Worth Federal Statistical Research Data Center with the support of AHRQ, the Agency for Healthcare Research and Quality. However, the results and conclusions are those of the author and do not indicate concurrence by AHRQ or the Department of Health and Human Services. Furthermore, the content is solely the responsibility of the authors and does not necessarily represent the official views of the National Institutes of Health. Thank you for listening to my presentation.